everyone, and welcome to our final installment of Money, Power, Respect webinar series hosted by the National Dental Association's New Dentist Committee. We spent the past few months diving into financial foundations and emerging technologies, and today we conclude the series with respect. Our final speaker is someone who embodies this very theme of today's session. Dr. Deshpande is a passionate advocate and expert in special care dentistry. Dr. Deshpande brings deep insight into how general dentists can inclusively and confidently treat patients with special healthcare needs and complex medical conditions within the comfort of a private practice. Dr. Deshpande is a graduate of University of Washington, has completed a GPR at Alameda Health Systems, and trained in the LEND program at University of Washington. She serves as the clinical director for Special Smiles at the NorCal Special Olympics and lectures nationally on accessible, compassionate dental care. She is also the author of Persevering, and her upcoming book on special care dentistry is highly anticipated. It is an honor to welcome such a trailblazer to close out our series. Please join me in welcoming Dr. Deshpande.
Hi, everyone. I'm super excited to be here. Thanks, Ruben, for the introduction. Yeah, I'm very, very excited to share what I am super passionate about. And I am just going to go ahead and share my screen and get this presentation started. All right, everyone can see my screen, yes?
Yes.
Okay, so feel free to stop me at any point, ask questions, or if you can put it on the chat, then Ruben, Marcus, Chanel, one of them will stop me in the presentation and just ask, because I love for it to be more as interactive as possible. So today we're going to talk about special care dentistry for general dentists. I'm assuming a lot of you are general dentists or are dental students. If you're specialists, hopefully you can take something away from this as well. But please let me know in the comments, what kind of field you are working on in dentistry. It'll be good to know. So as a disclosure, no part of this presentation is being sponsored for any for-profit entities. My purpose is only to provide timely information to general dentists and dental students that will increase access to care for people with special healthcare needs. As a poll, I would love to know if you are currently seeing patients with special healthcare needs in your private practice. Even if you are just seeing them once and then maybe referring them out for sedation, or you're referring them out to a hospital, or if you are seeing kind of the full A to Z spectrum of, doing the full A to Z spectrum of dentistry for these patients, I would love to know where you are. It just gives us an idea of, your experience and where kind of your comfort lies. Let's see if there's anything in the chat. So most of you are general dentists, which is great. Dental education. Some of you, okay, retiring from general dentistry. All right, maybe new things in the horizon. New things, new exciting things. Okay, we will let the chat populate with time. Perio, awesome, okay. And also see patients with special healthcare needs. That's great, welcome, welcome. So, and okay, some of you are experiencing limited patients with special healthcare needs. That is also great. Great, 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 awesome. Starting administrative, FQHC, that's kind of where I did my training for my GPR. So I started at an FQHC. I am trying to move this a little out so not everyone has to see the chat. Okay, all right. But that's awesome. Thank you for sharing. So a little bit about me, as Ruben already mentioned, I do portable dentistry. So I see patients at their homes, or I will see patients at skilled nursing facilities. Sometimes they're in assisted living centers. and or they are at what we call PACE centers. Depending on where you are in the country, you may or may not have heard of them. But PACE centers are centers for seniors or people with disabilities where they receive all of their services at one spot: medical, dental, mental health. They have an adult daycare center where they have all these activities. So I also visit those centers to see patients. And most of my patients are people with special healthcare needs or they're elderly. And then I also get referrals from general dentists in Northern California. I practice in the Bay Area. All right. um, what you will learn today. Now, we have very limited time, so I apologize in advance for not being able to go into detail about different things. This is usually at least a 4 hour or an 8 hour class. So I can go into lots and lots of detail, but just in the interest of time, we'll kind of touch on the basic stuff, and I hope you still take away a lot of things. We'll go over the ethics and principles of seeing these patients. We'll talk about accessibility. A lot of us kind of forget what accessibility actually means. We only think about it in terms of the physical accessibility requirements. So I'll talk about what else it entails. We'll go over some common medical conditions. I'll focus on the 4 most common things you might see in practice. Um, and then I'll go over what medical dental integration really means. This is a key component, and this is, in my experience, what scares most dentists away from seeing these patients, because they're like, oh my God, they have diabetes, they have all of these other, conditions. And it kind of scares us that I don't want this additional liability on my head. So maybe I should just send this patient to a specialist. This kind of complicates a lot of things, but if you think about it, if I'll go over it in detail today, it can be very straightforward, so it really shouldn't scare you. I'll talk about some business protocols, how you can implement care for these patients in your practice starting tomorrow. What is the structure that we follow in seeing these patients? We'll go over some decision making regarding treatments and materials. I'll share some of the fun stuff I like to use every day, which makes my life easy. It makes my assistants' lives easier. Patients love it. I'll show you some of those things. We'll talk about informed consent, which is pretty critical in this patient population. Informed consent basically talks about power of attorneys, conservatorships, guardianships. These seem like heavy words, but they're so common in this patient population. Once you start seeing them, you'll get kind of used to these things, and your team will become more comfortable understanding what these are and how do you actually work with these people. And then lastly, we'll talk about how you can go the extra mile should you become very interested in seeing this patient population. So ethics and principles. I like to start with definitions, even though it's very academic. It seems almost like dental school, but it actually gives us a lot of information. So most people, when they think of special healthcare needs, they're imagining a certain kind of person. But really, the definition of special healthcare needs is very broad. It means any physical, developmental, mental, sensory, behavioral, cognitive, emotional impairment, or any limiting condition that requires that requires the need of like a specific medical management or intervention or some specialized service. So if you think about it, a lot of people have special healthcare needs. It's not just the typical person you're imagining, in your mind right now. It could be anyone. The condition could be congenital, or it could be developmental, or it could be acquired. So over the course of someone's life, they could have developed some special healthcare need. So you may have had a patient who you've been seeing for 40 something years, and suddenly they've hit 60. Now they have different needs, and now their care is going to change in your practice, and they want to still see you. They want to see you because you are their general dentist or their prosthodontist or their periodontist, but they just have they have developed some different kinds of needs. They still want to be seen by you. They don't want to be pushed off to another person. So we have to still learn how to care for these patients because they want to see us, right? So that was kind of my spiel on how you might see a person in a park, and they might not look like they have special healthcare needs, but they do. How do we know about this as a dentist? We have to ask. So our team has to become really well trained about asking people, hey, do you need any modifications in practice? Do you need any help in accessing the medical history form? Can I help you fill it? Do you have someone who can help you fill the form? Do you need help getting to the office? Do you need help leaving the office? Do you need help going to the bathroom? There's so many little things that make a patient's life much easier, and they might not feel comfortable asking you, but if they're asked by you, they will tell you. So we have to just kind of become really good at asking these questions. Most of our medical history forms do a good job about asking that. If that question is not there, it needs to be there. Very important. It also needs to be there on your website, and I'll talk about that in, I think, the next section. Using person first language. Most of you know this already, but we can't say certain things anymore. We can't say special needs patient. We can't say autistic patient anymore. Really, the better way of saying is people with special healthcare needs, or a person with an intellectual or developmental disability, person on the autism spectrum. That's kind of the terminology that patient population has come up with for themselves. They would like for us to use that, so we should just respect that. Second section, accessibility of your practice, website, and marketing. So remember how I talked about how we mostly think about just physical accessibility because we imagine people in wheelchairs. A lot of patients are not on wheelchairs, but they still want to access your practice in terms of your website or your marketing. If you think about websites, so there are lots and lots of websites that are actually not built for someone who has a cognitive disability or a certain visual disability. They are not maybe able to access that website. It's a problem. There's actually, if you Google this case, you might find it, but there was a law firm that would actually just specialize in hitting different kinds of businesses with lawsuits on the fact that their website was not accessible. That's all that law firm did. And it was a problem because they hit many dental practices with that. So believe it or not, some things like this can happen. The reason I put JFK here is because his administration was kind of a pioneer for people with special healthcare needs. Some people know this, but one of his sisters did have an intellectual and developmental disability, Rosemary Kennedy, and she passed away because of an unsuccessful medical operation. But her basically her life was one of the reasons why Special Olympics, which is an international organization at this point, was birthed into life. His other sister, Eunice, she was the one who actually started Special Olympics and began advocating for people with special healthcare needs. So if you go around and meet a lot of people in the community, self advocates, if you meet people with disabilities, they will kind of credit a lot of their progress to his administration, which kind of set the wheels in motion. The American Disabilities Act is something all of us know. It was set in 1990. The act created the national mandate for eliminating the discrimination against people with disabilities. So the act protects three kinds of people: a person that has a physical or mental impairment that substantially limits a major life activity, somebody who has history or records of such impairment, or is regarded as having an impairment. So it really does not even need to have, a person does not really need to have like a physical, like a history or a record. It's just someone who is regarded as having an impairment or someone who needs an accommodation. So again, the ADA is also very, very broad. Dental offices have to remain compliant with it in many different ways. Number one, we adopt a non-discrimination policy. All dental offices in the United States do that. When scheduling an appointment, again, as I mentioned before, our team should really ask patients if they need an accommodation because of any kind of disability, what that accommodation is, how can we make their appointment as smooth as possible. Every team member should attend training on compliance. It's actually mandatory. We all should be doing that. And you should be getting renewals also once every year, once every 2 years, that kind of thing. Every office needs to have actually an ADA coordinator. So somebody who is like your go-to compliance person on everything. That person should be in charge of maintaining the standards in your office. So think about these things when you enter your office tomorrow. The ADA standards for accessible design, again, there are so many regulations, but think about accessibility in its broader scope. Physically, obviously, you need to make sure the path is very clear for the patient to move around. A lot of the wheelchairs are no longer kind of standard made, right? Some of them are, I think of them, I almost call them little mini cars. They're like a mini car for a person because they have all of these funky controls. Those chairs can do so much. I have 2 or 3 patients who have dental chairs. Oh, not dental chairs. They have wheelchairs that become dental chairs. So they lean all the way back, and the patient, it almost looks like I'm walking, with a dental chair. So I always tell my patient, like, you guys are my favorite patients because my back remains straight. I can be ergonomically taking care of my team. But it's amazing. The problem is that when you're seeing them in a traditional dental office, those huge chairs don't have a lot of space. So what do you do? When I was in residency, we often ran into this situation where someone would come in on a wheelchair, and then you're trying to get them into a dental room, which already has a big chair. And now the wheelchair has to kind of go around it. It's actually not great. From a safety standard, absolutely, it's not at all a good situation, because if something were to happen, for that patient who's in the wheelchair, there needs to be space for us to bring that patient out of the wheelchair onto the floor and do CPR or whatever is needed. So there needs to be enough wiggle room around their chair. So if you in your physical space in your dental office, if you don't have enough space to see that patient while they are in the wheelchair, maybe you shouldn't see them in the dental op. Maybe you should see them in your reception when there's no other patients. Maybe see them at 8 o'clock in the morning when the office is like empty, before you see your first 9 o'clock patient, and see them in the reception where they could be on their wheelchair, and just bring your stuff there. So think about different ideas that will make the patient more comfortable, because squeezing them into that narrow little corridor around the dental chair might not be a good, just not be a good design, not very safe. Cognitively, think about all the disabilities that are, quote unquote, invisible: alcoholism, someone on the autism spectrum, someone having Down syndrome, someone having traumatic brain injury. Just the other day, my assistant and I went to see a patient. You could not tell by speaking to her that she has had a traumatic brain injury. It was only when you look at her medical records that oh my God, she's had a brain injury, and it is relatively recent. So she repeated a lot of things while she was talking to us. She kept saying, I have this toothache and I can't move. I can't move. And for anybody else, you might just think like, oh, it's like, this patient is just kind of keeps repeating the same thing. You wouldn't know unless you look into the records, or unless you do a little bit more investigation, that, okay, she's had a traumatic brain injury, and that's why she's behaving the way she is. And that's why she needs a different level of care from a dental standpoint. So we should just give each patient an opportunity to inform us of their disabilities, and we need to basically do our job by looking at the medical record. In your op, and this is just a great little tip, even for if you see a lot of kids. We call them leaving breadcrumbs. So leaving breadcrumbs are like if any of you are parents of little kids, you know what I'm talking about, where you give them lots of different sensory toys so they're constantly engaged. If they're done with one toy, then they need to have another toy. So the way we do that in a dental office is on a wall you have so many different sensory toys. And this is just an example of stuff to like hold on to, some stuff you can squeeze, touch, watch, you can play with. There could be like rolly toys that you can kind of grab, but all of these things kind of help with it just helps with sensory abilities. So it makes the experience of waiting in a waiting room a little bit easier, less stressful for people. Remember that a lot of patients with special health care needs attend your appointments with other people. So they might bring maybe a parent, they might bring one or two friends, they might come in with a social worker. So you need that space. So instead of having like, chair in a waiting room, maybe you want to keep like a group seating when these patients are arriving. And because you know that they are going to come with a group of people. In terms of accessibility for your website, there's something called Web Content Accessibility Guidelines 2.0, which all websites, all over the US actually should be following, but specifically, definitely healthcare practices should be following this because it's a legitimate reason for a lawsuit if your website is not accessible and patients cannot make appointments or cannot access different parts of your website. So think about that. And of course, we all know about the dimmable lights, and we know about fidget toys, so I won't go into that in detail. Section 3, review of common medical conditions. So I'll go over a few big medical conditions that you will definitely see in your practice in some way, shape, or form. And then we can talk about some others as well. The biggest one is intellectual or developmental disability. As you know, it's indistinguishable. Physically, you may not know if someone has a disability. You have to ask. Many of these patients have something called polypharmacy. Polypharmacy is when a patient is on 5+ medications. And actually, a dentist can be a really big, can play a very big role in this. I have seen a lot of patients on a laundry list of medications. And sometimes you will see that they are on so many medications, they might be on 2 of the same medication because there's all of these different healthcare providers that they're seeing. Some of us are not cross-referencing what the patient is already on. They might be on multiple pain medications. They might be on 1 or 2 blood thinners. You will see this once you start seeing this patient population, you'll see that they're on like 10, 15 medications. So you can play an active role in this situation and then just send a message to the primary care physician or get on a call with them and say, hey, I'm noticing that Mr. X is on 15 medications. What is going on? I found that a little concerning. I am doing 5 extractions next Monday. I want to make sure that there's adequate pain control, but they're already on these pain medications. Should I not even give him anything because he's, already satiated in terms of pain medication? So you might want to have that conversation, and that might trigger something on their end. They might think that, oh, you know what? Maybe he's on too much. Maybe I can taper it down based on his tolerance level or whatever. So never underestimate the role we can play. We can play a very, very important role in their lives. We tend to see high incidence of caries and perio. That might be because just over time, a lot of patients with intellectual and developmental disabilities have not had the best dental care. And so you see just because of so much time has passed that they have not had dental care, that is why you see a high incidence of decay and perio. There may not be something biologically that is causing this high incidence, so just keep that in mind. But you do see a lot of malocclusion, and that indirectly contributes to the decay and the perio. Communication, AAC, stands for augmentative and alternative communication methods. A lot of patients you might see bring in a book or they bring in an iPad. or they bring one of those tablets which has a stylus with it, and that's how they communicate, because they might not be verbal. So asking this ahead of time can just help you a whole lot. Your appointment will be a lot smoother, because imagine trying to go through that to treatment plan some complex dentistry. It can take a lot of time. So just keep that in mind, that if you have an idea how the communication is going to look like, your appointment will go a lot smoother. They also really crave consistency. So sticking with the same dentist, sticking with the same hygienist, for example. I know it's not always possible if you're working in a big, like a group setting or in a hospital setting. This is hard, but these things really matter. If you can't keep the dentist or the team consistent, um, consider putting in notes for each appointment so that the next provider can read the notes, know what to talk about, know what their favorite food is, favorite animal, whatever it is, all the little things that make patients, unique. Uh, the next provider is aware of that, so that you kind of have that little bit of a connection. Down syndrome, again, very, very commonly seen. Once you start seeing patients with special healthcare needs, you will come across people with Down syndrome. Physically quite distinguishable. So midfacial hyperplasia, low set ears, a broad, short head. They tend to have cardiovascular complications. However, a lot of patients will have their heart conditions managed within the first 1 to 5 years of life. So from a dentistry point of view, what you would need to do is basically do a consultation with the cardiologist to make sure that, okay, if there is a heart murmur or if there is some kind of valve in there, you are aware of it. Mainly when you're doing sedation or general anesthesia, that's when these things have become kind of very important. Or if you need to do antibiotic prophylaxis for any dental treatment, that is another thing you want to know if they're at risk for anything. A lot of patients tend to be obese. Obesity basically should lift up your eyes and ears towards the incidence of OSA, obstructive sleep apnea. The reason obstructive sleep apnea is a problem, of course, there are lots of problems with obstructive sleep apnea if you do have a patient with that. But the biggest thing for us in terms of dentistry is sedation. You do not want to sedate these patients if they are, above like a BMI of 35 or 40. It becomes very, very risky at that point, mainly because their airway is super, super tight. Trying to get an airway in there in the event that you need to, it just becomes very complicated. So if you want to see this patient, you may want to see them in a general anesthesia setting where you have an anesthesiologist, but please be aware, even anesthesiologists will sometimes not want to see patients that have a BMI of over 35 or 40 who are obese, who have obstructive sleep apnea. They don't want to see these patients either. So it becomes really complicated when we go into that. But, hopefully, um, at least the patients who are of a lower BMI, you're still able to manage them with a lot of desensitization. Nitrous can be really, really great for this patient population. I wouldn't recommend oral sedation, mainly because you cannot titrate it, and it can have really, really variable results on different people. So I'm not the biggest advocate for oral sedation, but a lot of my colleagues will use that. Um, Down syndrome, high incidence of perio, low incidence of caries, mainly because their teeth are very spaced out. So you don't see a whole lot of decay. For most of my patients, I will have a strict 3-month recall. Even if they're just oral prophylaxis patients, if it's just like a regular prophy patient, I will still want to see them every 3 months if I feel like they're not really brushing their teeth at home or they're not getting help brushing their teeth at home. So you have to make that call once you see that patient on, what their home care looks like. Many patients can be candidates for ortho, so don't always dismiss it. Have a consultation with an orthodontist who is comfortable seeing this patient population, and then, go from there. Yeah. Cerebral palsy, you might start seeing patients with cerebral palsy once you start seeing all of these patients. It's an abnormal development or damage to the brain, usually occurs either before birth, during birth, or in the first 5 years of life. Patients tend to have feeding difficulties, so most of them are fed by a G tube. What that does is, because they're not getting a lot of food through the mouth, what happens is that they have high perio risk, so a lot of tartar. So cleaning the mouth, I would even 3 months sometimes feels very less, because every time you see these patients, there's just a whole lot of data to clean out. And it becomes really, really challenging even for the caregiver to do that. But that doesn't mean that they shouldn't. I have noticed that if you give written down instructions and actually put things on a prescription, so if you want them to, rinse their mouth twice a day with Listerine or some kind of mouthwash, put it in a prescription. Once it's in a prescription, the caregiver has to mandatorily follow that. It's not like they can do it as they want. It has to be done. And I've also noticed a lot of caregivers are very, very scared of upsetting a patient. But the thing is, it's like every patient is going to be upset. Nobody wants their teeth brushed. I have a 1-year-old. She doesn't want to have her teeth brushed either, but they have to be brushed. So there are certain kinds of toothbrushes that I really like and I recommend to my patients. One of them is called Surround, Surround. It is sold by a company called Specialized Care Company. I have no financial interest with them. They just make products that are specifically made for people with special healthcare needs. So that toothbrush really works well. You can brush up both sides, all three sides of the tooth, like buccal, lingual, and occlusal at the same time. That's why the brush is really effective. And you can just have a caregiver brush the patient's teeth really effectively with that. Not 100%, but at least you can get to 60 or 70%, right? So highly recommend that brush. Another product that I like is the open wide disposable mouth prop, which a lot of you already have. It looks like white thermocol, which you kind of stick onto one side of the mouth, and that helps the patient keep their mouth open. And then you use the brush to, brush the other side. So I will demonstrate this when I go and see patients in their home, and I will show the caregiver, see, this is how we do it, this is how you can do it. And then they will actually come in and do it themselves, so that they, it's like tell, show, do. If you try and educate caregivers like this, it'll be really beneficial, because they are very scared. They don't want to upset the patient. So that's the reason a lot of our patients will come in and, it looks like their teeth have not been brushed for days, but it's really because the caregivers are scared. So just, you have to try and help people where you can. Dementia. If some of your specialists out there, you might be already seeing a much older population coming into your practice. So you might have these patients who are maybe, they were okay for several decades, and then now you're starting to see that they are developing maybe some signs of dementia. It becomes really challenging. Patients with dementia are super, super challenging to work with. Mainly because, especially if they don't have a medical power of attorney. So ideally, patients with dementia should have designated somebody else as their medical power of attorney before they have had a loss of intellectual function. That's the correct way of doing it. You can't have a medical power of attorney made after you've already started experiencing signs of dementia, because at that point, you're not considered to have enough capacity to have designated somebody else, right? So it can become very complicated. The thing about dementia, what I like doing is I'll ask the patient, do you have family or friends you can trust that you can bring with you to the appointment, that, who will be there during your appointment? And some patients will say yes, some patients will say no, I don't have anybody, or they will say, okay, I can have my caregiver come in. Because I had one patient who kept asking me to call her daughter, and she just would not let us take x-rays or do anything without her daughter. So for those of you in the Bay Area, maybe you will understand, but we were kind of in Mountain View, and her daughter was in Palo Alto, and in rush hour traffic, even though these two cities are a little close, it can take up to 45 minutes for someone to get to from one point to the other. So we waited those 45 minutes till her daughter came. I called up her daughter. I was like, hey, I'm seeing your mom. She really wants you to be there. We're just going to take x-rays and do an exam and a cleaning. She's like, okay, I will be there, but it'll take me 45 minutes. Like, fine, you're coming. So in those 45 minutes, we saw other patients because we happened to be at an assisted living facility where we had other patients, so we could do that. I know you may not have that time in your private practice schedule, so just knowing this in advance will help the appointment go smoother. If you know that they have dementia, have them bring someone. If they are losing teeth, should you treatment plan a prosthesis, a partial, a denture? It's a question mark. There's no black and white answer, mainly because if they are experiencing dementia, do you know if they are reliably going to remember to even wear the partial? Are they going to lose it? Are they going to learn how to wear it? Because partials are not, yes, they seem easy to put in and out, but if you think about someone who is elderly, who is already experiencing dementia, it's a slippery slope. So planning this big prosthesis can be challenging. So you really want to make sure that the patient understands as reasonably possible, and that they have a team of people around them who can help them in making that decision that, okay, yes, a prosthesis is important because we need them to eat. If they are not able to eat because they have such less teeth, they're going to lose their appetite. That's another slippery slope. You don't want to be in that situation where you haven't treatment planned a denture for a patient because now they have lost the ability to eat and they are eating lesser food, they're losing weight. So it can be very difficult to treatment plan this patient population. So I think clinically as a dentist, having a mentor who you can discuss these cases with is really, really nice. And for the patient to have a group of people that they can make these decisions with. A lot of education for these patients, lots of education. Section 4, we're making progress. I do want to leave the last few minutes just for questions. So the next few sections will be relatively faster, don't worry. Achieving medical dental integration. This is really key. If you don't remember anything from this whole hour, this is the most important thing, super, super important. This also, in my experience, for my colleagues who refer to me, this scares everybody because they see the medical conditions and they're like, oh my God, there's so much going on with this patient. I'm just going to, refer them to a hospital. So most of us ask for this thing called medical clearance from our physician friends. The medical clearance, if you send them that, they're just going to send it back saying that patient is cleared for dental treatment. They're not going to give you really the details that you're looking for, because what we are really looking for is, okay, this patient is on blood thinners. Are they going to bleed out if I do full mouth extractions? Do you want me to do anything different? Or this patient has an A1C of 10. I need them to be at a reasonable HbA1c level before I do full mouth extractions because 10 is too much. There's going to be risk for infection. Or you're asking that this patient has like this big neck. They have this big neck. They have a BMI of kind of 32, 35. They are saying that they're kind of snoring and not getting the best sleep. Can you please do a sleep study? Does this patient have risk for obstructive sleep apnea? Because I want to see them in my office with sedation because they're super anxious. A lot of patients with special healthcare needs will be anxious. This is totally common, very, very common. So they will need some form of sedation, and you're trying to debate, oh, should I do nitrous or should I do IV sedation? Should I get an anesthesiologist in for the day? You're trying to make that decision. So the question you should be asking is this patient optimized for complex dental treatment, including, these number of extractions, fillings, blah, 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 with moderate sedation, with, nitrous, blah, blah, blah. in an outpatient setting, that's what you really need to be asking. And I always ask for a history and physical. I don't ask for a medical clearance because I know that if I send a medical clearance, it's going to come back saying that they're cleared. Because for most physicians, cardiac, you know, cardiac surgeries, brain surgeries, these are the two kinds of surgeries that they are actually like worried about. For them, dental surgery ranks at the bottom. They think dental surgery is like, getting fillings, getting a cleaning. Unless we give them the detail that we are expecting from them, they're not going to give us anything. So ask for a history and physical because that will actually give you a lot of information. Ask for specific blood tests. If you're worried about bleeding, ask for their liver function tests. If you are worried about diabetes, get their A1Cs. A1C above 10 is a no-no. It needs to be lower. If you're looking for, I mean, it really depends on what specifically you're looking for, but ask for those blood tests and then interpret them and then go from there. Another good way of doing this is actually having a teledentistry appointment. At this time, we are not doing that, but in residency, we did that routinely. For every patient, we had a teledentistry appointment, which was just 20 minutes. It doesn't have to be super long. It also need not have to be done by a dentist. It could be done by a highly trained dental assistant or a highly trained office manager or someone in the administrative department. Basically what it is, it's just getting medical history from the patient and their supported decision makers, whoever their POAs are or guardians are. And just going step by step. Okay, does this patient have this? Does this patient have that? It just takes away the stress of doing that in person. And you kind of know already how to communicate with that patient because you've kind of seen them on the video visit. You know what they are like, you know what they kind of like, don't like, and you can tailor make your meeting based on that. It lessens the ambiguities. You can set aside half a day for these phone calls, for these follow-ups. I've also noticed physicians and other healthcare providers are so much nicer when you talk to them on the phone. You get a lot more information over the phone versus somebody, when you're just faxing stuff over because things get lost in translation over paper. So just pick up the phone and call and then make a detailed note about what your conversation was. Remember that most people are not good historians. So even if you do like this whole teledentistry visit, you get the medical history from them, you're not going to get 100%. You're going to get most of the 100% in the history and physical. You will. If you have the benefit of being at an FQHC, as some of you are, and you're working with something like Epic, Epic is the best system because if you are a dentist working on Epic, you can just message a physician, a cardiologist, whoever is on their care team. You can ask them, hey, I'm doing blah, blah, blah for this patient. Is that, do you have any recommendations for pre-op antibiotics, for changes in their, blood thinners, anything like that? You can just ask them that question. So it's just great in terms of communication. It's a lot faster. I have no connection with Epic. I just really like the product compared to most of the dental practice management systems, which really don't give you any idea about the patient's medical history. So just my 2 cents on that. Oh, sorry, I'm going backwards. Business protocols. This is kind of the fun stuff that, will help you really implement this stuff Monday. For any patient that is seen for the first time, account for a half hour extra than you usually would. So if you're going to use a 1 hour for new patients, I would say 1.5 hours for new patients. If it's someone with special healthcare needs. I usually have this thing about scheduling, which I can share with you. It is something I learned, once I learned how to do sedation. Diabetic patients, I like to see them first thing in the morning, always. First patient in the morning if they have diabetes. And if they have hypertension, first thing in the afternoon. Because the thing you're worried about hypertension is, for the patient to have a stroke or a heart attack, and you do not want to be the first stressor for them in the morning. Let them, take their medications, have a slow start, have their breakfast, have their lunch, do everything, and then see you at 1 o'clock. You will have a much better appointment in the afternoon than you would have had at 9 a.m. Don't see those patients at 9. And diabetes, mainly because of the food and everything. If you're seeing them for sedation, just first thing in the morning is just always better. See only one patient at a time. These patients will not do good if you are hopping around from one patient to the other. Just see one patient at a time, take care of them, then let them go. It's really, really hard to context switch when you're seeing someone with multiple medical conditions, and most of them are kind of complex. First appointment really should be like a high and by appointment. So desensitization, which is like have them see the dental clinic. This is the dental chair. This is where you'll be seated. You'll be sitting. This is my assistant. It should just be like a no stress appointment. For some patients, even cleaning can be a little bit stressful. But a lot of patients will allow you for cleaning, but x-rays, exam, just chat, come up with a game plan, get everyone on the same page. That's it for the first patient, for the first appointment. That's all it should be. These are also some things that I love using. There's something called airway positioner. Some of you might be using them already, but it just helps keep kind of the head up, the chin lift thing. It just helps keep people positioned properly so that you're not worried about them kind of collapsing, the airway kind of closing. These are just issues that I've noticed over time because a lot of our patients are overweight or obese. And the airway can be a big problem when you're doing a lot of complex dental treatment, especially on the bottom. If you're doing a lot of like number 30, 31, 29, like all of these treatments on the bottom, people's chins tend to get closed and then the airway kind of closes. You really don't want to have these issues, especially with someone with medical complexities. So always use airway positioners. If you're seeing patients in their wheelchairs, there are these pillows that are, you can think of them as like body pillows. So they're like it's a very long pillow which has kind of these little sections that jut out at the ears. So a patient can very comfortably get treatment while sitting on their wheelchair with the help of that pillow and still be in the optimum position for you to do dental treatment on them without them feeling kind of uncomfortable. Because the biggest thing about wheelchairs is that when they lay their head back, there's nothing at the back. The wheelchair kind of cuts off at the level of the shoulder, so having that wheelchair support really helps. All of these things can be found with the same company, the Specialized Care Company. That really is kind of they make all of these products. So really, if you were to buy something, I would recommend that. Or there are some other companies. There's one called Sedation Resource. Any company that really offers stuff for sedation will offer these same products. Stabilizing wraps and boards. I'm not a huge advocate for them, but there is a place for these things in the dental office. If you do use stabilizing wraps and boards, which is basically like a pillow that holds the patient, it's very different from what we have all learned in dental school. It's not a papoose board. It's a very breathable fabric. So in the full day long seminar that I teach, I actually show people how to use this. And I have participants actually put it on for each other, and they find that it's actually very cozy. It's like you being swaddled when you were a baby, right? It's like that. But you have to have consent forms signed when you're using this. And the best way is actually to show a video to the patient and their family that this is what it's going to look like. If you're not okay with this, we will not use it, but this will make the patient a lot more safer to treat, because some patients move their hands around a lot. So you should have a specific informed consent signed prior to using these kind of things. My philosophy: treat fewer patients, spend more time with each, make one patient happy. You make one patient happy in this patient population, they will send you 10 referrals. That's how your referral network just grows. Make each patient happy, because believe me, there are not a lot of dentists who are seeing these patients, and that's exactly why you should see them. and continue networking with other healthcare professionals, because there's teachers, there's social workers, there's physiotherapists, occupational therapists, all of these people who are working with the same patient population, who are looking for you. They're looking for dentists who can treat these patients. So if you find the time to network with other healthcare professionals, it'll be great. And lots of team training. I recommend at least once a month at minimum to do medical emergency team training with your teams. Very, very important. Decision making on treatment modifications and materials. If we just have a few more slides, I'm going to speed through it so we have enough time for questions. As I mentioned, I'm very strict on prevention, 3-month minimum recalls. It's shorter if I believe that the patient is not getting adequate home care. Lots of caregiver education, have small realistic goals. We use a ton of silver diamine fluoride. I did not use a lot of silver diamine fluoride when I was in private practice. I'm not sure why. I actually use it a ton now, especially for back teeth, especially if I'm seeing a patient who's like 75, 80, they have dementia. Family does not want to extract teeth, but I see that there's like a lot of issues with their teeth. I will use a lot of silver diamine fluoride to just give them whatever benefit I can. It's an excellent tool for palliative care. It's also an excellent tool for pediatrics for baby teeth. So really use, this is a tool in your toolbox. Do not ignore it. It actually works. And of course, these are some other options: glass ionomers, composites, IV sedation, general anesthesia. Navigating informed consent. I did talk about this briefly, but figure out who is helping patients make decisions. A lot of patients make their own decisions. Ask them that. Is somebody, do you have a medical power of attorney? They will tell you yes or no, because if they do have one, they will tell you. You don't have to guess. Ask them if they have a conservator, if they have a guardian, because these are usually the people who will then pay for any treatment. And you need to understand who has the financial responsibility, who has the decision-making responsibility. Some of them have what's called a supported decision maker. Here I've written surrogate, but there's something called SDM, supported decision maker, which is basically maybe a person who has a husband, a spouse, or a best friend who helps them make the decision, but ultimately the decision is being made by themselves. So they will have to have this person at the appointment every time they are making like treatment planning decisions. So you have to ask these questions, and ideally, healthcare providers need to be reviewing paperwork, confirming that, okay, this is a power of attorney, because then you're going to be sharing confidential healthcare information with that person. So you have to make sure that you're dotting all your I's and crossing your T's when you share information with someone else. So this is the slide about supported decision making, which is gaining more and more popularity now because a lot of people want to be their own decision makers. The last section is kind of going the extra mile. I know a lot of you are, in private practice or in dental school, so you're seeing patients in this traditional dental setting. But like Ruben very recently has started this, but we are doing portable dentistry, so we're going out in the field. And it's just a great opportunity to do these things, mainly because there's not a lot of dentists who are out in the field seeing patients at their homes. It's an excellent service to be offering to people. Because if you think about it, they have to accommodate for a whole day's activities in order to make it to the dental appointment at your practice. They have to have someone drive them. That other person has to take the day off work to come drive them. They have to be driven back. The wheelchair is a whole thing. Like, is it a big wheelchair? Is it a small wheelchair? If it's a big wheelchair, it doesn't fit into a traditional car. I have had a patient who lives just 4 or 5 blocks from where I live. And she has such a huge motorized wheelchair that the motorized wheelchair doesn't actually fit in traditional dental offices. It's so big, it doesn't fit through a regular door. So I needed her to be seen for a redo of a endo. on number 14 or 15. I don't treat second molars for root canals, right? Many of us general dentists don't do that. And this was a root canal that was already treated some years ago. So it needs to be retreated because I saw some gaps in it, and it needed a new crown or something. Literally, there is no endodontist who can accommodate her chair. It's like an unfortunate situation. So we had to kind of figure out what to do with that tooth, and we ultimately decided to extract that tooth because we couldn't find an endodontist. So these are legitimate problems. If you are able to go into the patient's house and offer them services there, it's a game changer, total game changer. If you decide to do this, you can start small, identify assisted and independent living centers in your area, go and introduce yourselves to them. And you can just do very simple things like exams and cleanings. That's it. You don't have to do a whole lot of things. Reach out to RDHAPs if they are licensed in your state. These are registered dental hygienists in alternative practice, I believe is the AP stand form. But basically, they are like us. They go out into the field and see patients at their homes, assisted living facilities, skilled nursing facilities, wherever they are, and they complete hygiene for them. And they have to work with a dentist to do teledentistry appointments because every 18 months there needs to be an exam, and that needs to be done by a dentist. So our DHAPs are looking for us. So just keep that in mind. But yeah, I hope all of you got at least a little bit out of this presentation. I tried to zip past through it because there's so much. It's a broad topic. But I just want to end by saying people with special healthcare needs are already in your practice. You may not know that, but they are there in your practice. And maybe they are looking for more from you, and you can be the person providing that for them. You don't have to refer them out unless it's super complex. Identify a mentor in your region, in your area, who you can kind of just brainstorm these patients with. Get permission obviously from your patient before discussing their care with someone else. But they're looking for you. They want to be treated by you. There's lots of different opportunity there, and if you help them by taking care of their needs, they will refer 10-15 patients to your practice because they will be so happy. And these patients are looking for dentists and struggling to find people who can care for them. So I hope you are able to offer that service to your community. Thank you so much.
Wow. Achieve medical dental integration. Remember that. And I got some 7-year-olds that don't want their teeth brushed. So you got a 1-year-old, I got a 7-year-old.
Yeah.
We have our survey that we're asking everybody to fill out. And while we're filling out that, we have a couple questions for you in our Q&A.
Okay.
All right. So first is, can you recommend a few websites for those sensory, wall, object, noise canceling headphones, etc.?
So let's see if I can think of a website. You should be able to get them anywhere, like noise canceling headphones. I mean, we just got them off of I think Amazon or eBay. But the sensory wall objects, there are actually some specific websites which I don't have right now, but I can I send them out to you, Ruben, and then maybe you can,
Of
send
course.
them to yeah, because there are some websites that make them, and they're really useful.
Second question, who holds the liability for sedation? The anesthesiologist or is it the dentist is also liable for the decision to acquire a sedation provider in their clinic?
Great question. The answer is the dentist. Yeah, it's always the dentist. Even if you bring an anesthesiologist, you bring a CRNA, you bring anybody else, it's always the dentist. It falls on the dentist. So we have to really do everything. So in like the 8 hour, the day long thing that I teach, I actually teach airway exam. So you have to do like a Malampati score. You have to do all of those things to make sure that this patient is safe to treat in your office, or B, do they need to be referred? As a rule, I only see patients up till ASA 1 and ASA 2 to be seen in my office by me offering the sedation. If the patient is ASA 3, we will have to have a consult with a dental anesthesiologist and see how comfortable they are. We have to do all of the, we also have to go through risks and benefits for the patient, like with the patient, that, hey, these are some issues. We are feeling a little bit unsafe about this. Maybe you should be seen in a hospital. But know that even if it's an ASA 3 and they go to the hospital, just know at the back of your head that they might be declined at the hospital because they are also a huge liability for an anesthesiologist over there. And you have to prepare your patients for that, hey, these are some issues we see. That's why we are not treating you here. But if we get you to a hospital, they might say no too. And these patients are going to be super duper disappointed with you when you say that. But it's just life. You have to be safe. So great question.
All right, we got another one. Would you send the complete dental treatment plan over to the doctor for medical clearance, or just the treatments that we are confirming possible contraindications for? Do you give a brief summary about what the treatments are on the plan? Likely the doctors don't know what the treatments are. That's why I asked.
Yeah, no, that's a great question. You don't have to give them a full treatment plan. They may not even understand, because of the, like, setting them like number 8 ml composite. They're like, what is that? So they might not get it, but I just kind of send them like a broad overview, 5 extractions, 10 fillings. Fillings are not too scary for most people. It's mainly the extractions that most people are concerned about. Or if you're doing implants, if you're a prosthodontist and you're doing a lot of implants and stuff, and the reason you're asking is diabetes and blood thinners. Like, these are the two big reasons you're figuring out, or antibiotics, right? So give them just a brief summary of what you're doing, how much time it's going to take. I'm a general dentist, so I am seeing patients for max 2 hours. That's kind of my limit. I don't want to see them beyond 2 hours because um, it's just a big problem, especially if they're sedated and they're not eating anything. It's a whole host of issues. But if you're a prosthodontist or a specialist, you're likely seeing patients for 4 hours, 5 hours. So put in the time also that you're going to see patients, that they're in an outpatient setting. And if you're doing sedation, which medications are you using? Are you using fentanyl? You're using midazolam? Like, what drugs are you using? Because again, the more information you give to these people, the better response you will get. And when in doubt, just do a phone call. But great question.
One last question. What specific devices do you prefer for adult cerebral palsy patients who remove the mouth prop from their own mouth during prophy? Also, any suggestions for taking bite wings with cerebral palsy patients, getting patients to hold on to XCP? Thank you.
Yeah, that's a great question. So the removable mouth prop, like the open wide mouth prop, some patients will yank it out. But that's why there is something called the cranky mouth prop. If for those of you who have been through GPR or you've been in a hospital setting, you know that the cranky mouth prop is, if you just Google it, you will see what it is. But it's basically this device that once you kind of attach, it's really hard to take out once it's in there. You have to know how to put it in and actually use it in order to do it safely, though. So you have to get trained on how to use it in a safe way, you or your assistant or your team. But once it's in there, the patient is basically going to be open. The other thing is they might be moving, even if the mouth prop is in there, their head might be moving, which is why, remember those tools in the presentation I talked about, like the stabilizing wrap. There's basically head pillows that also keep the head in one place. Those things will help make your life easier because then the mouth is open and then the head is, in one position. So you can take your x-rays, and you have to be very quick. You have to be quick about your x-rays.
Wonderful. Before I outro, we have the honor of having our Madam National President here, Dr. Baptiste. Could you say a few words for us?
Good afternoon. Thank you everybody here, Dr. Sorrell, Dr. Roberts, Dr. Horton, Mr. Ware, all of the guests for participating, for your involvement. Dr. Deshapande, I wanted to thank you because of the way that you presented all these complexities and some cures. It's just vital to the future of inclusive dentistry. So your contributions, as well as your upcoming and current publications and your continuing lectures, is just invaluable to us. So we greatly appreciate that. And I have one quick question about the Curadot, the hydroxyapatite regeneration medicament. Have you found any effectiveness with this? I know you said you're using other things, but I wanted to find out about that.
I have actually used it and it does work. So whatever as a rule, if there is like a new product that you're kind of looking at, I use this website called Up to Date. Or if there's another, I mean, you can always check PubMed, just go through evidence and see, you know, what has been there in the literature. Have people found success with it? If you're using a new product and there's not a lot of research on it, talk to patients and tell them, hey, this is new, it's been around just for 5-6 years, there's not a lot of data on it, but I would like for us to try it. What do you think? One of my mentors used a ton of preventative medications for patients. So he would put patients on like this huge, almost laundry list of oral hygiene preventative appliances and medications, like, you know, silver diamine fluoride, 5,000 parts per, you know, million fluoride, like toothpaste, this and that, Listerine every day, mainly because he would see patients for comprehensive dentistry in a hospital setting. And then he would see the same patient 6 months later. Now they have new issues because we don't know what happened in those 6 months. And it's very disappointing when you see that as a dentist, because you're like, oh my God, I put all of this time. And then if you have to take that patient back to the hospital, you can't do that very easily. It's a whole thing again. So trying to get their home care as good as possible is so important. So I absolutely agree. We have to just do the studies for using these new products and try and use them for our patients.
Thank you.
Yeah.
Thank you so much, Dr. Deshapande, for the informative, compassionate, and truly necessary session. Your guidance and practical steps for building inclusive dental practices will no doubt shape the way we approach care in our communities. As we conclude the Money, Power, Respect series, I want to thank all of our speakers and attendees for your engagement and enthusiasm. This series was created to empower our new dentists and just all of our dentists because of your participation and wisdom shared today. Be sure to stay connected with NDA. We have our upcoming 2025 NDA conference in Kansas City. Also, we need you to get your membership. Come on, if you haven't already renewed, we need you to do that. Thank you again, Dr. Deshapande, and just thank you all for being a part of this journey.
Thank you so much for inviting me. This is an amazing Sunday morning. Thank you.